Thank you so much for your kind introduction. It's great honor to be here to present about this topic today. And thank you so much for inviting me, Chairperson. And actually, you have already enjoyed several topics about this kind of topics already presented by previous lecturer professors. So I'd like to more focus on the prokinetics, such as 5-HT4 receptor agonist. I'd like to briefly introduction, such as definition and prevalence of functional dyspepsia and pathogenesis, and then move to the diagnostic and therapeutic algorithm of functional dyspepsia, and then prokinetics, and then I'd like to summary. Based on the diagnostic criteria for functional dyspepsia, must include one or more of the following, such as bothersome postprandial fullness, early satiation, epigastric pain, or epigastric burning. And there is no evidence of a structural disease, including at upper endoscopy, that is likely to explain the symptoms. And also criteria fulfilled for the last 3 months with symptom onset, at least 6 months prior to diagnosis. The functional dyspepsia subdivided into 2 categories. The one is the postprandial distress syndrome, and the other is epigastric pain syndrome. Here is the prevalence of a functional dyspepsia. In Korea, approximately the prevalence is 8%, and in China and Taiwan is approximately 23%. In Japan is approximately 17%. Here is the possible pathogenesis of a functional dyspepsia, such as gastric dysmotility and visceral hypersensitivity and gastric acid secretion and psycho-emotional impact, and also H. pylori infection. Here is based on the pathophysiological mechanisms, we can see several kinds of dyspeptic symptoms, such as postprandial fullness, nausea and vomiting, and epigastric pain and belching, and sometimes weight loss. Here is the diagnostic algorithm for functional dyspepsia, especially in Asian primary care settings. A diagnosis of a functional dyspepsia can be considered on the basis of clinical symptoms and upper gastrointestinal endoscopy results. Other useful informations for dyspepsia include complete blood cell count and blood biochemistry test, and patients with dyspepsia should be tested for H. pylori infection and stool examinations for parasites in areas with high prevalence of infestations, and also fecal blood testings are also useful. And sometimes upper abdominal ultrasound or CT scan may be employed if indicated clinically. This is the management algorithm for functional dyspepsia. This slide is already detailed, addressed by the Professor Somchai. I'd like to move on next one. Here is the development of prokinetics. At the first time, the central peripheral dopamine D1 and 2 antagonist, such as levosulfide, developed. And then central and peripheral dopamine D2 antagonist, such as metoclopramide, clavopride. And then peripheral dopamine D2 antagonist, such as domperidone and etopride, and recently peripheral 5-HT4 agonist, such as mosapride, developed. Here is the subgroup of prokinetic drugs. The one is the D2 receptor antagonist, such as metoclopramide, domperidone, and etopride. The other one is a serotonin receptor antagonist, such as cisapride and mosapride. Here is the mechanism of action of prokinetics. Prokinetic agents, including mosapride and cisapride, stimulate digestive motility. Both agents are thought to stimulate serotonin 5-HT4 receptors in the GI plexus, consequently increasing the release of acetylcholine and hence enhancing GI motility and gastric emptying. However, cisapride, which acts on serotonin receptors 5-HT1 to 4, has been associated with potentially fatal heart rhythm abnormality, and this agent has been withdrawn from several markets, including the US. Mosapride, which has little effect on potassium channels, is an alternative prokinetic agent that can be safely used in patients with upper GI disorders. Metoclopramide, domperidone, levosulfide, etopride acts on D2 receptor antagonist and also influence antagonist and alternative prokinetic agents that can be safely used in patients with upper GI disorders. But these kind of drugs also have a special influence on CNS, such as metoclopramide as a blockage of the dopamine D2 receptor agonist has a special effect on CNS depression, extrapyramidal syndrome, or some kind of hyperprolactinemia. Also, cisapride can influence on QT prolongation, resulting in torsade de Pointes. So I'd like to focus more on the prokinetics, such as 5-HT4 receptor and mosapride on functional dyspepsia. Mosapride shortened gastric emptying time according to the studies conducted in volunteers and patients with Parkinson's disease and patients with diabetes. Here is the effect on gastric emptying. In 8 patients with chronic gastritis, gastric emptying was assessed by double sampling test method. It shortened by 19% after treatment with a single dose of mosapride. And here is another study on effects on gastric motility in Parkinson's disease. As you know, selective 5-HT4 agonists have no or minimal adverse events on the heart and CNS, possibly because of their highly binding selectivity. Some investigators evaluate the clinical efficacy and tolerability of mosapride in an open-label study involving 5 patients of Parkinson's disease who have response fluctuations and evaluated gastric motility by a radionuclide gastric emptying test. Here is the result. Mean gastric emptying half time before treatment was longer than the control value, but gastric emptying time significantly decreased during therapy, and also increased awakening time and also increased daily activity and motor function. In conclusion, despite the small number of patients enrolled in this study, results provide the first clinical evidence directly showing that increased gastric emptying and also motility during treatment with a selective 5-HT4 receptor agonist reduce response fluctuation and also improve motor functions in Parkinson's disease. Here is the effect on the GI transit by capsule endoscopy. To determine the effect of oral mosapride on gastrointestinal transit time and the diagnostic yield of capsule endoscopy, 60